What we're going to do is we're going to go over plantar fasciitis. And what Dr. Henne and I are going to talk about is just like people that are here. Usually if you have plantar fasciitis and you're somebody who it's lingering, this is probably a good place for you to be right now. So we can just talk about what are other options and stuff that we've tried before, stretching, icing. You know, there's a whole spectrum of plantar fasciitis. So in our practice, we try our best to bring, whenever we see something that might be beneficial to our patients that we've read throughout the literature or that we see in practice. One of those examples would be things like platelet-rich plasma, the regenerative medicine part. That's been around for a long time, but it was something that we were kind of, let's see if people do well with this and get better. The other thing that we've started in the last 2 years is we have the 3D scanning to do custom orthotics. In the last 2 years, we worked with this really good group out of Canada. And what we do is we digitally scan the foot with this facial recognition software that it's like, and we're able to capture every nook and cranny of the foot. We're able to put it in this CAD/CAM software. So we have your foot in the actual computer, and then we can actually make the orthotic to your foot. It's really freaking cool.
And if you don't like it, we can adjust it. You know, it's easy. You go down, you move a little thing, you do a little dish.
The best part is we wind up casting a patient within 24 hours. I can actually have your orthotic to you. So that's the orthotic piece. And then we actually have a representative from this company that is called Alleviate, and they have a couple of pretty unique ways to help with the plantar fasciitis. They have a massager for the foot, so we'll maybe be able to see a demonstration of that. Just a little bit about our office. If you haven't been here, we both are trained surgically out of West Penn Hospital in Pittsburgh. We're nice people. We're privately owned, so we own our own practice. So we're not in a big corporation, so we don't have to live under some restraints. Like we don't have to see this many people an hour. We don't have to, we're married to each other. Nobody
tells us what to do except she tells me what to do.
Right.
We're married.
So we have a very nice dynamic because we don't have to see 4 people every 15 minutes. And we're just big on exhausting all forms of conservative care. So we're not always jumping to the operating room. And particularly for plantar fasciitis, people don't do really great with surgery. But what is plantar fasciitis? I put this picture in here, and I included this picture of what the plantar fascia looks like. The fascia is a very long, wide, and it's a very thick structure. So I always explain to patients that it's a very resilient structure. So people for years and years and years can be slowly developing this over time, and that's why it can be chronic and in this stuck position. But I always tell people, if you look at our legs, we all have a little bit of muscle in the front and a whole lot more muscle in the back. This back muscle, the most superficial, that gastrocnemius soleus, it becomes your Achilles tendon, which is the biggest tendon in your body. And what happens is it inserts in the middle third of your heel bone. So when we're at rest, because this muscle group's job is to bring our foot up, this muscle group's job is to plantar flex, to invert our foot. That fascia, when we go to bed at night or for resting, it gets completely contracted. So when you try and get up in the morning and take that first step, or you've been sitting for a real long time, or you go on a long car drive, you get up, go like this, and the fascia kind of tears, and you get all these little micro tears over time. Would you agree with that?
Exactly. So the beginning inflammation is. It hasn't quite tore, but it's thinking about tearing.
And I feel like that's the most common scenario we see people with plantar fasciitis is just over time, that muscle imbalance that we're all kind of born with. Like in my slide here, it says genetics. Well, we all genetically are built like this. I don't think it's that you can blame your mom for plantar fasciitis. But anything else to?
I guess the easiest way I explain plantar fascia, it's an injury like any other injury. When you go to bed at night, your injuries try to heal up. And then as soon as you get out of bed in the morning, you screw it up, and you screw it up all day. We literally get you better by trying to trick you into healing up more at night than you screw up the next day.
Yeah, no, and to that point, I always tell people, in the morning before you get out of bed, you should always be stretching that posterior. So you've been contracted all night. Lock your knee, bring your foot back towards you. Get a nice deep stretch in that posterior muscle chain, and it'll stretch that plantar fascia because that's huge. I always tell people, if you do not stretch, so the physical therapy part, if you do not stretch, you never get better. So my patients who come in and they're like, I don't really stretch, I'm like, well, you're never going to get better. You got to do it. You got to do it. Um, Absolutely.
In the acute phase, would you suggest like to brace it?
So yes. So like in the acute phase, so we have people come in, and I always tell people, and these guys have a great product for this brace. But what happens is in the acute phase, if you're like, hey, I got up 2 days ago, my foot is killing me right here, right in the arch or right in the medial tubercle heel here. I always tell those people, like, you're going to do amazing. If it's brand new and you've had it for like less than 3 weeks, we do some stretching, some icing. That's where that low dye taping, like I was saying, like sometimes people go to doctor's office and they put all this tape on. I'm just not a big fan, but having something where you can brace it right away, and you can. The other thing with plantar fasciitis is people think, how long do I have to take off from doing my thing I love, whether it's running, walking, pickleball, and we always tell people, usually with plantar fasciitis, you can still be active, and we kind of encourage that.
Yeah, my goal is to get people to do what they want to do. I usually tell people like to blame running. So I say, well, yeah, I like to run. Well, how often do you run? Well, I run about 3 miles, 4 or 5 days a week. Well, that's about 30 minutes. So if you want to keep running, you don't necessarily have to give up running, maybe give up something else. You know, for instance, if you have a job where you're on your feet 12 hours a day, see if you can sit down a couple minutes, figure out something other way. So the biggest thing we do is we kind of help people cheat through life, because life normally gets in the way more than the problem. The problem's there no matter what, but sometimes you got to cheat with life as well.
Yeah, and I mean, I agree with that. But yeah, but in the acute stages, those are the people that do the best. I have a cheat sheet in every treatment room, and it's just a picture of 3 stretches. They're posterior muscle chain stretches where, you know, I always tell people, if you can, because, you know, we see a lot of people who've had knee replacements and completely recover from that, in the sense they can't get that full extension. So, but I tell them, if you can lock your knee, bring your foot back towards you before you get out of bed, do some wall stretches, basic runner stretches. Don't go barefoot. I tell people I love the UFU flip-flops. If you've ever seen those, they're like the big, fat, meaty flip-flops. So when you're walking around, you're not like straining the fascia with each step. But yeah, and then something like bracing it's not a bad idea. But bracing it so you can still be active with it. I don't like people, unless you've ruptured your fascia, I don't put people in boots or anything like that. Unless it's traumatic where something really horrific has happened. I don't do that. Does that answer your question? Yeah, I think it's a good idea. And I mean, I've had plantar fasciitis twice in my life, 3 times, all in the same year in my lifetime. And I always tell people I learned from my mistakes, because what I did the first time was I did the stretching, the icing, no barefoot, and I was better in 2 weeks. And I was like, I am superhuman. I am so great. And I just stopped doing everything. And I always tell people it's 6 to 8 weeks of fully doing that. And then I got it like 3 months later. And I was like, how did this happen? But it was because I stopped stretching. I stopped everything. I think it's a good idea to stretch forever. And then the last time I got it in the same year, I got better. I did everything I told my patients to do for 6 weeks. And then at Christmas time, I was baking cookies with my kids barefoot for like 4 hours. And then I had plantar fasciitis. It took me forever to get rid of it, but I did. But it's hard work. You know, it's not always easy. And this is just a histological slide. It's a little bit, you know, like what a healthy plantar fascia looks like versus a fascia that's been damaged. And the slide on the bottom, there's some chronic degeneration. And this is another reason why when people come in and they want a steroid shot, I'm not right away jumping to it, only because every time you put a steroid in, and we tell people steroid shots, we use them all the time. We use them for different things. It's not my favorite thing to do, but sometimes patients need it. And so, but this is an indication of just the cells there's like collagen necrosis, the cells are damaged. When you put the steroid in there, it is a good, nice temporary relief where you can get, and then if you have a steroid shot and then you're doing the stretching, icing, good supportive care, you can get better forever. You don't have to jump to like a PRP, but that is a nice alternative, which is more natural and regenerative. Do you have anything?
I usually try to explain to people, pills and shots don't cure anything. They make you feel better. They're meant to get you through when you screw it up. For instance, if you cook cookies all day long one day, you take pills and shots. And very commonly, we'll give somebody a shot. And they'll come back and say, that last shot lasted a couple months. And I giggle and laugh and say, no, that shot lasted about 1 week. You just went a couple months without screwing it up.
Yeah.
Pills and shots are temporary things. They're supposed to get you through a rough patch. Your job is to figure out how to keep it from coming back. And whenever it does come back, jump on it right away. If you're relying on pills and shots, it's never going to get better unless you just stop doing what you're doing. So I tell everybody, if you just stop walking, you'll be fine. The problem is most of us have to walk around because we can't fly. So it's we kind of got to figure out what you need to do in addition to shots.
I put the slide in here because if anybody's ever had plantar fasciitis, it does feel like there are things that can mimic plantar fasciitis, and I have a slide on that a little bit later. But plantar fasciitis people, the number one thing people always describe, I imagine opening a textbook and I could see that patient in there. I get out of bed in the morning, that first step in the morning is very painful. Or on the flip side, I've been on my feet all day, and after so many hours, it starts to hurt because I have a standing job. Some people, they long car drive, get out of the car, bam, they've got that sharp, like almost stabbing pain right there in the heel. Activity, when they start to use it, will start to feel a little bit better, but then can hurt after a while. And to your point too, like for plantar fasciitis, our body has a lot of cells that our body doesn't want us to be in pain. So there are some natural cells that come in and help relieve that as you start to use it and warm it up. People always ask this with plantar fasciitis. I don't know that this slide's in the right order, but I will just say there are certain shoes that we do like. Obviously, we're not brand ambassadors for any of them, but I love, I have this white pair of these New Balance Fresh Foam. I think they're awesome. The only thing that sucks is we went to Disney and they got black on the tips of the toes. So they were like my dress sneakers, and now I'm like, crap. But I like Brooks and I like Hoka. Hokas aren't for everyone. I have some patients who are older. We send them over to a sporting goods store and they'll try on the Hokas and they feel kind of unstable because it is kind of a thicker. And I like Allbirds. I don't know. These are Allbirds. They're the only reason I like them. They're supportive, but they also are waterproof. So I like that.
We do kids soccer.
So we have kids that play cross country and soccer. So you go on the grass in the morning and it's all wet and yucky. These don't get wet. So
I have used all three of those for running. So I interchange. They're good for a year or two, and then change them. You got to do another.
Is it on the ALL Birds?
Thank you.
Yeah.
And I like them because they're kind of dressy so they're not really dress shoes, but they have a bunch of brands that kind of look like dress shoes. You can wear them with jeans and khakis and stuff like that. Still be comfortable.
So stylish. So stylish. Who's at risk for plantar fasciitis? I just kind of went over this. I think everybody's at risk because we all have that muscle imbalance. As far as this guy is just not as strong as this guy, but we do see it. Our patient population, we see a lot of people between the ages of 40 and 60 and older and younger. If they're kids, it's usually not plantar fasciitis. Their parents will diagnose them with plantar fasciitis. They'll come in and they have calcaneopophysitis, which is a growth plate that eventually goes away. We see a lot of runners with plantar fasciitis just from repetitive micro trauma. Not all runners get plantar fasciitis, but we do see it in a high portion of them. People, I always tell people, even with people who are a little overweight or a lot of overweight, I don't think plantar fasciitis is caused from excess weight. I really do feel like it's more the muscle imbalance. I don't know how you.
Scientifically, one would say obviously it does, but I see more people who aren't overweight with plantar fasciitis than that do.
Oh yeah.
Because they're trying to get busy. It's more what you're doing, injuring it, than anything.
Yeah. Pregnant women, just pick on pregnant women right now because it's not getting all the way. But I think it's the hormonal changes. And then just bad shoes, standing all day. And then ironically, people who have really flat feet sometimes get plantar fasciitis. But the ironic thing is high arch people, when they get plantar fasciitis, it's harder to get rid of because it's harder to get them into something simple. Yeah. I just wanted to touch on bone spurs a little bit because patients come in all the time and they're like, oh, I was diagnosed with a bone spur before, so I probably have a bone spur. And I always explain to them that there's this thin membrane around your heel bone called the periosteum. And it's as I've gotten older, it's easier to do this, but it's like a thin membrane. And what happens is it can tent up when the fascia, so go to bed at night, your foot's been contracted all evening, you try and take that step. Remember, I showed that picture of the fascia. It's a very strong structure. It's very thick. It's wide. So it pulls on that whole periosteum of the bone so that the bone doesn't want to break and the fascia doesn't really want to rupture off. That bone tense up. And then that's how we get these kind of spurs happening. And on the flip side, we see a lot of people who have plantar fasciitis who have no bone spur. And we see a lot of people who come in for like a bunion, a hammer toe, a fracture of somewhere else. And they'll have like a big honking heel spur like this big, no pain, because their body keeps adapting over time. I tell people eventually your body's like, I don't care.
I usually say spurs are the result of your problem, not the cause. If you've had it on and off, you may get a spur, but we never do anything about the spur. I've never touched a bone spur in the bottom of the foot ever operating.
I did. But my first 5 years of private practice, I did not a lot of bone spur, but I did at least.
I'm talking, but you touched the spur?
Yeah. I used to do open, this is like a side conversation. I used to do open endoscopic, I used to do open plantar fasciectomy with a bone spur resection. I don't do that anymore. And I wanted to go over prevention for plantar fasciitis. You know, I always tell people, and there's a couple different schools of thought and worlds where when they collide, the people lose their mind. Like there's a group of people who believe in like barefoot walking, barefoot, you know, all that stuff. And I don't think that that's necessarily terrible. There's a lady, if any of you have ever gone to the park run in downtown Claremont, on Saturdays, there's a lady who runs barefoot on the trail, which I think is
The pavement.
crazy, but she does it and she swears by it. So I don't like, it works for some people. I will tell you the majority of people, since we were babies, our parents slapped little shoes on us with little support. And I feel like our barefoot's terrible for if you have plantar fasciitis or somebody that's prone to plantar fasciitis. I would throw my barefoot days away because you will continuously struggle. I'm not a fan of memory foam, you know, in a sneaker. Like I have a lot of patients come in, they have the Skechers with the memory foam. The memory foam, your foot just shrinks down into it. So if that doesn't have, I feel like some of those Skechers slip-ons are getting better as far as what the last of the shoe is.
As well.
But high heels, flat ballerina shoes, all those things are kind of bad. Why'd you make that face back there, huh? Yeah. We see it. Tim and I did a
The wood ones?
Yeah.
I despise them.
Not the good ones.
The clogs.
If you get the rubber ones, they're fine. Don't get something gushy back there. They're fine. Because they used to make those dance goes. They called all the nurses that come in with these hard shoes. And so you realize why they sell those, right? You guys buy those because you buy one pair, they last you 10 to 20 years because they're hard on the bottom. They're miserable. You're better off getting a pair of Crocs and switching them out every 6 months because at least it's nice and gushy in the bottom.
We used to have this podcast. It was short-lived because at the time we had all 3 little kids. We're like, I can't do this crap and do everything. But it was 2 pods and a microphone. And we did one where we went to Disney and we took, this is really not great, but we took pictures. We're like, all right, Lily, go over there by that guy's shoes. And she's like, what? And like, we took a picture of the person's shoes. And she's like, are you kidding me? I'm not even in the picture. I was like, no, shh, come on. And we took pictures of all the types of shoes people wear to Disney. And we're like,
not Disney approved.
Not Disney approved. That was fun though.
That was fun.
And avoid over exercising. Like there's a point where you can do too much, you can stretch too much. There's all those things. So you have to have a happy balance.
And we're saying shoes. We're not saying go home and throw all your bad shoes away. I tell most of my patients, pretend dress shoes or something you think is pretend it's like a margarita. You would never drink margaritas all day long and be surprised if you felt like crap the next day. Dress shoes are the same thing. You wear them for a little bit. You do this and stuff like this. If you've ever been to a wedding reception, what are all the women wearing at the end of the night? Nothing. Because men invented those shoes so you couldn't get away at the end of the night. You need to wear something comfortable if you're going to be on your feet more than a couple hours.
And I'm sorry if I'm boring you guys, but I'm trying to. We talk about treatment. You know, the treatment I think is, you know, I am a huge proponent that the stretching is probably that physical therapy piece of it is probably the most important part. Some people say you don't need ice. I'm a huge fan because when I just anecdotally, when I had plantar fasciitis, I had 4 of those little ice bottles in my freezer all lined up, hard as a rock. And when I'd sit down and do paperwork, I'd put it on the ground and I would roll that sucker back and forth, and it always felt good. And it was like my own at home physical therapy. So I'm a huge fan of that. I just think it works. I think it's good. It doesn't work if you don't use it. I always tell patients, you know, massaging the foot and wearing supportive devices. Like I said, these guys have a brace that you can put on for plantar fasciitis and for posterior tibial tendonitis that is really giving this kind of strapping effect and really supporting that arch and that that load bearing part of the foot. We have custom orthotics and we have over-the-counter orthotics. We tell people all the time, not everybody needs a custom orthotic. Over-the-counter orthotics, if they're made well, they do really great for people, especially if it's the first time having plantar fasciitis. If you're struggling with it, it means you probably need something more custom. I put the steroid shot on here because it is just a very common, what happens in a lot of offices, happens in this office as well.
I use them all the time.
But it's because insurance will cover it for patients. So that makes it, it's cost effective for the patient. We always tell patients when we do steroid shots, we don't do more than 3 in like a period of time. And then they've got to really work at. I tell a lot of patients, for me, I feel like it's one and done. About 75% of the people we see who we do give a steroid shot, they get better. Like in 2-3 weeks, they're like, wow, it's gone. But I hammer in their head. I give them that sheet of paper with their home physical therapy. I'm like, these are the things you need to do forever.
If you don't want to see this again, don't just take a shot. You got to do all the other stuff.
Yeah.
The shot just makes you feel better for a week. Everything else keeps it away.
On the flip side, the PRP, it's platelet-rich plasma. And I have a little video of what we do for that. But the platelet-rich plasma, it's awesome, but it's totally the difference. It's like a total 180. But
it's a way to get it to heal.
It's a way to get it to heal, but it doesn't feel great right away. Because it's actually bringing the cells into the area to heal that tissue. So it's a very different beast than a steroid shot. So, but they're both comparable. Again, I'm beating up steroid shots a little bit because there are things that patients, and it can cause fat pad atrophy. It is short-term relief, but a lot of people get better for a long period of time with it. It's in the standard of care. That's why a lot of people do it. Like I said, we're a small practice, so we don't have to, we can sit and explain all the other stuff and other options to patients instead of being like, okay, you hurt, all right, get me a shot. Oh, we'll shoot this person, you're out the door, next person. That's just not how we operate here. The PRP, we kind of went over all this side. I say the biggest downside of PRP is that insurance doesn't cover it. So that becomes like a out-of-pocket expense. So patients have to weigh that, This is a little video I made on PRP.
At the Center for Ankle and Foot Care, we understand
That's
the
me.
importance of staying active and avoiding invasive surgery whenever possible. That's why we offer platelet-rich plasma therapy, PRP, an advanced treatment that harnesses the power of the body to heal itself. PRP is a regenerative treatment where we draw a small amount of your blood, process it to concentrate the platelets, and inject it into the affected area. These platelets release growth hormones that speed up the healing process and reduce inflammation. PRP is especially effective for conditions like Achilles tendonitis, plantar fasciitis, and arthritis in the foot and ankle. These common issues can cause pain and limit your mobility. With PRP, you can promote healing without the need for surgery. Our goal is to keep you moving, keep you active, and keep you out of the operating room. PRP therapy offers non-invasive natural solutions to your foot and ankle pain. If you're dealing with chronic pain in the foot or ankle, let's explore how PRP can help you stay active. Contact us at the Center for Ankle and Foot Care.
I know that seemed like a little promotionally, but I just wanted to see how how it all is from our YouTube or whatever.
You do that in the same.
Yeah.
We do that. Yeah, we have a
At the
little.
Center for
Oh,
Ankle
sorry,
and Foot Care,
guys.
we understand.
Because I'm stuck. Oh, there we go. But yeah, we do that here. We do it on. Like when I do the Achilles tendon, I usually do that ultrasound guided. The plantar fascia, you're shooting the same area, but for the patient's mental health, if they feel like they need to, I don't use it for the plantar fascia. I do want to go over the surgery again. This is that slide of, this is what's called an endoscopic plantar fasciectomy. You did these.
Yeah.
This is where you stick a camera in one side and you stick a blade in the other, and you're just looking, it's like a video game because you're never looking at the patient's foot after you make those 2 little incisions. And what this is that white tissue you're seeing is the plantar fascia, which is very thick. And they've already cut through it a couple times. And then that pink in the center is the muscle belly. So when we used to do this, and I do not do this surgery anymore, I think it's abysmal.
Yes, what I tell people is the plantar fascia is like a wet paper towel. So you got a little tiny hole there, and that's what hurts. So what the surgery does is you take that little tiny hole and you just make it, instead of one little hole, you just make it this big. And then you limp around for 3 to 4 months.
So yeah, so
And
there's
nowhere else in the body do we just destroy something more and go, well, let's see what
basically you
happens.
rupture the fascia is what you do. And then I stopped doing this, there's actually in the physical therapy literature, they've done studies where they compared endoscopic plantar fasciectomies to just putting somebody in a fiberglass cast for 4 weeks straight. And the people in the cast did better, except for a little muscle atrophy, but because it was constantly held in that stretched position. So, and I think there's more complications. If you ever talk to somebody and they're saying, hey, you should get surgery for this, do not get surgery for this.
Yeah, I see 2-3 people a week are coming here. Well, I guess I need surgery. I've done all this stuff somewhere else. I'm like, have you tried this? Have you tried this? Have you tried this? They're like, no, I haven't. I had one shot. I haven't tried arch supports. I haven't gone to physical. I haven't done anything. You know, they see the doctor once. You get a couple shots. I'm ready.
And then like, I need
it
surgery.
Seems weird. I saw them twice. They said we got to operate. I'm like, well, I see 10 to 20 people a day, every day, and I operate on one every 5 or 10 years for this. What have you done? And they've 9 times they've done nothing.
Yeah. And I mean, I think the complications of this are worse than the actual plantar fasciitis. You could live with plantar fasciitis. And
it's a great way to get it work for 6 days.
But people wind up, some people actually get a flat foot from that if the surgery's done incorrectly. Or they get pain on the outside of the foot. It's called lateral column pain. So don't do that. And I think this is probably the most important slide. We have people come in and they're like, oh, I have pain in both of my heels. It's killing me.
At night, it's burning.
Yeah, it's burning. It's tingling. And they've
already had 2 surgeries. Why did it work? Well, it's your back.
It's their back. They'll have a lower lumbar radiculopathy. So, and those are the people. It's very hard. I'll have a patient come in the first time. They'll describe bilateral heel pain that hurts them only at night. And sometimes if they're standing for long periods of time.
The thing is, they're allowed to have both. So you push on the heel hurts, but most of the pain's at night. Well, I can get that walking around stuff better, that burning stuff, so that's your back. And you really got to work with those people.
But to see a patient for the first time and they just look at me like I'm crazy. They're like, no, it's not my back. You're the foot doctor. What are you talking about? And we're like, well, like we could send you for a nerve conduction study. And they're like, I'm not doing that. And you're like, well, I've had a patient who was a nurse at the hospital and this is going back like 15 years ago. The orthopedist is not here. He's not living anymore, actually. But I saw this nurse. I said, it's your back. Let's go for a nerve conduction study. She's like, I don't believe you. She went to an orthopedist in town. He did bilateral endoscopic plantar fasciectomies on her. She came and saw me a year later. She had the same pain she had before. I mean, this is an orthopedist. Like he could have helped her even with her back, possibly. But we got the nerve conduction studies, and she had lower lumbar radiculopathy, which means the pain, because of where that is and where those nerves come out of the vertebrae, that's the part of the foot that's affected.
Yeah, it's like bumping your funny bone. You hit it here, it hurts down here. Same concept.
Another thing people can have is a local compression neuropathy in the ankle. It's called tarsal tunnel. It's kind of like carpal tunnel in your wrist, but it's in the ankle. I don't think it's really common though, and then if it is that, we just do stretching, icing, no big deal. Some people develop what's called Baxter's neuritis with their plantar fasciitis. Those two things sometimes go hand in hand. If somebody's had plantar fasciitis for an extended period of time, the fascia gets a little thicker each time it tears. And right superior to the fascia, there's the first branch of the lateral plantar nerve, which is called Baxter's nerve. And that can get inflamed just from the fascia pushing on it. And less common stress fractures. I do have your guys, these guys have, I'm like a huge fan of physical therapy for almost everything, because I do believe we can heal ourselves just doing some simple things. And there is a device which is a massager for the foot. And I don't know, I tried to, when I first opened it, I couldn't figure out how to open it. And then I was like, oh, this is pretty cool. It's like a Chinese star, like how it's kind of designed. But I don't know if you guys want to show how to use that.
Yeah, for sure. Alleviate. So hi everyone. My name is Virginia. I am the CEO of this company called Alleviate, and Boop, who is grabbing all of our products over here, is the co-founder of Alleviate. So he's a physical therapist, and he's just going to hand out a couple of demo devices so that you all can experience the types of massage that Dr. McGowan was describing. Just to give you a little bit of intro on the product. So to Dr. McGowan's point, all of our products are based in gold standard physical therapy techniques. And so has anyone tried physical therapy before for plantar fasciitis? Yes.
I'm not sure if that's what I actually have.
Okay. But yeah,
You would probably.
so physical therapy is a great solution. It's a great treatment option for you, especially if you're looking to not only look for sort of non-invasive treatment solutions, but also to make sure that you're kind of throwing everything at the pain that you're experiencing. Because to Dr. McGowan's point, you can't just shoot up a steroid and cross your fingers and hope that it gets better. You really have to be an active participant in your own care. You have to take it into your own hands. And so physical therapy is a great option to do that.
Yeah, one of my friends said that helped her a lot.
Yeah. But the kind of the challenge with physical therapy is that it's really hard to get an appointment. So the average time to your first appointment takes 26 days. So if I called Luke's physical therapy office today, it would take me 26 days. Well, his practice is a little bit better, but if I called a physical therapy office, it would take me on average 26 days just to get into an appointment. So imagine living for 26 days in this terrible, terrible pain and really not being able to do anything in the middle. So that's why we invented our products. It's so that you can have access to really, really high quality physical therapy care at your own home and do all of the different types of treatment that a physical therapist would do on you, either in between visits to a physical therapist or as an alternative to physical therapy. And so again, Luke will demonstrate and kind of describe what this is based on. And then after that, we'll have you all try it. This is a foot clinic, so we won't be shy about taking our shoes off and putting our feet on things, because the more you can try it, the more you can experience the difference, the better. And to Dr. McGowan's point, you can then figure out really what types of solutions are going to work best for you. It's a lot of trial and error for this to make yourself feel better. And so the more things, the more products you try, the longer you stick with it, and the more consistent you can be, the better. And so I'll hand it over to Luke to kind of describe the science behind it and give you a little bit more info.
I'm Luke. I've been a physical therapist for 20 years. I came up in New Zealand working with professional sports teams. And I would work with those teams and the athletes, and you'd work on somebody 2 times a day, and they would get better. And then I came across to the land of the free and the home of the brave. And I was seeing people that were 6 months, 9 months, 12 months down the track, and they were still in pain. And I was like, why? Why are people still in pain? And so plantar fascia is really simple, but plantar fasciitis is really simple, but it's very, very complicated. The arch is like a spring. When you stand up, it flattens out. When you take the load off it, it recoils. If you put too much load through it, I'm going to consistently say that term load, but if you put too much load through it, it gets grumpy. Micro tears happen, small tears, and then those tears build, causes some scar tissue, and then that scar tissue causes you pain. Super simple explanation of what's going on. When Dr. McGowan was talking about low-dye taping does something called, it unloads your foot, so it lifts up your arch. It essentially creates like a suspension bridge. So if you imagine your arch has fallen down, this taping lifts it up a tiny bit. Problem with taping is after 15 minutes of competitive sport, the benefits of that taping, the mechanical benefits are gone. 24, 48 hours, if you're walking around, it may still give you some support, but probably not. So it's a very short-term solution. If you're older, it can rupture it can cause irritation to the skin. So bracing is a really, really effective medium to decrease the load going through your foot. When you have plantar fasciitis, you develop scar tissue in your foot and you develop pain. So we develop this massager here that if you open up, it's almost like a Christmas tree stand. You put it onto the floor, and what this is designed to do, you open this up, you put it down on the floor, and you all are going to massage your feet into that part of your heel. I have in my pocket something that I got through airport security, which is called a tongue depressor, and I will work on people's feet with this and break down some of those adhesions and tension. Now, I can't shake hands anymore with people because I've used my thumb for so many years to do this. So now I use this tool, and this is something called Graston therapy that's kind of like the gold standard. You can't do that on your foot easily, so we developed this thing to replicate that. Graston therapy has been proven to work. If you move your foot back and forth on this with some of the balm that we have, it will decrease the tension in your foot, break down some of those adhesions, and also create some new tissue if you use our exercise program as well. Physical therapy is great. You get a good physical therapist, go and see them. I'm all for that. But the average lifespan of a physical therapist in North America is 3.5 years. They're in, then they're out. And so you're getting a lot of new people that are coming through. They don't develop an understanding of the pathology. They don't develop a timeline as to whether you are getting better or not. And so we want to make sure that you are getting consistent care. If you have chronic plantar fasciitis, use our system. You have a 40% decrease in pain after 2 weeks of using our system. That's huge. So people who have had pain for 6 months, 9 months, 12 months, we capture that data in our system. We have thousands of people that have shown that after 2 weeks, you have a 40% decrease in pain. That's pretty massive. If you use our system for 6 weeks, the majority of people have a 60% decrease in their pain or discomfort. Our system shows you that you decrease your pain over a period of time using our massager, using our brace, and also structuring some of the exercises that we have in a very easy to use app. So we're going to get you, everybody, to just move your foot on this in that painful area of your heel, just to feel, you don't want to go fast, but just to feel what it feels like on that area of tissue. What I usually do in practice is have somebody try or attempt to do a heel walk, which is always incredibly painful for people with plantar fasciitis. And then I'll get them to do this for 3 or 4 minutes and retest, because that's what science is about, test, intervention, retest. And so if you do that, we always see a decrease in pain or discomfort.
So you'll just start with that little bottom low peak and rub your foot against it. Just glide your foot towards you and then glide it away from you. And what you want to do is, so I'm seeing everyone kind of sitting back and lounging a little bit leisurely. Lean into the massager a little bit, pull it towards you. So we're going to move this just closer to you so you can feel it.
Is that right?
And then if you lean your body weight into it, you sit down here,
And
put your foot right there at your heel, and then lean your body weight into it, and then glide what you want to do.
Okay.
You want to try it?
You get straight
And
into
then
that.
away. Yeah, so just glide it like that. And what you want to keep doing is just feel how, shift your body weight and then lean over it. Do you feel it putting more pressure through your foot? Yeah. So a couple of the sensations you should be feeling. It should feel a little bit crunchy. So you know when you get a really good back massage, you can feel the knots getting worked out. You should be able to feel some knots getting worked out. If you're not feeling that, that might be an indication you need to put more pressure through your heel.
Virginia has a very good answer to that.
Okay.
How much is this?
Oh, these are $79. And they're available for purchase in clinic today. If you buy it today, you also get all the products that are also included in that. So usually it's just the massager, but you can get, there's a little balm in there to use with it. The balm has arnica cream in it, which is a pain relieving product. So here's what I'm gonna have you do. I'm gonna have you slide forward a little bit. Put more of your body weight into it, and then glide your foot towards you. Just experiment with the product a little bit so you're feeling, so you feel a little bit more of that. How's it feeling for you?
Should I be doing this sitting down or standing?
Yeah, great question. So you want to be using this device when you're sitting, and what we recommend for people with plantar fasciitis is to keep it right next to your bed. So when Dr. McGowan was talking about your foot at night kind of goes like this, which causes that morning pain in the morning. So what you want to do is keep this right next to your bed. First thing you do when you wake up is you massage your foot on it so you can reduce the pain and the tension right away in the morning. What I'll also have everyone do, now it's been about 2 minutes that you all have been massaging. So I'm gonna have you stop massaging and I want you to all just stand up. Just stand up and feel, compare the side of the foot that you massaged against with the foot that you didn't massage against. So your sensation should feel like I see nods. How does it feel?
It feels like every day.
It feels relieved.
Yeah, like it's more.
Does it feel lighter?
Yeah.
Yeah, and it feels like a lot less tension. Yeah. So that's exactly what you want to be feeling and what you'll continue to feel. So you don't want to overdo it, especially in those early stages of plantar fasciitis. 2 to 3 minutes a day, morning, right when you wake up, keep it next to your bed, and then at night, do it right before you go to sleep so you can relieve that tension as well. You guys can sit down.
I'm going to talk for 2 minutes about compression socks. Everybody's heard about compression socks. There is a new evolution in the garment industry called 3D knitting, where basically instead of stitching things, having a flat pattern and then creating a circular structure and stitching through the back, you have a machine that has needles 360 around, and that will develop a product. So our socks don't have any stitches in them other than the toes and the ends, right? We have a circular knit pattern that creates our socks. Compression socks, the majority of compression socks are not compressed through the foot. And the reason that they're not compressed through the foot is so that they can do small, medium, and large and extra large sizes, right? So our socks are compressed through the foot. Medical grade compression is greater than 20 mmHg. If you're getting socks from Amazon or Lululemon, 8 to 12, sometimes 12 to 15, but 20 mmHg plus is what you need to try and return all of that fluid that pulls in your feet over the course of a day back towards your heart. You can see that our socks mimic what your foot looks like, and this is where the industry has gone over the last little while, so that when you slide your foot into the sock, socks used to look like this from side on. That doesn't look like your foot. We have a nice little heel pocket there. This part of it is not compressed, and this part of it is not compressed. But through the middle, you have true compression so that everything in your foot returns back up here. Really important that that's a differentiator of our socks to the majority of other things that are out there. Again, most socks are compressed from here to here, but everything still pulls in your foot. So when things pull in your feet, swelling is acidic. It irritates the plantar fascia, and so if you have swelling in your ankles, it drops into your foot. That can continue to give you your plantar fascia type symptoms. So make sure, you don't have to buy our socks, but make sure that when you are looking for compression socks, it's 20 mmHg plus, and that they have compression through the foot. These are super easy to put on because it mimics your foot. We did left and right. So you can just put the foot on and then pull them up. If you're looking at TED stockings, the white ones that are the gold standard at the moment, really hard to put on. I was talking to a couple back there, and they have to do it as a team, which is
Right.
really
No,
romantic.
it's true.
That's love.
It's one of the more romantic things I've But try putting these socks on, you'll be able to get them on, and just make sure that if you are having pulling or swelling in your feet, that you try and compress that and get rid of it, because that can make your symptoms last just a little bit longer.
My favorite thing that Lee talks about with these socks is that when you have socks that only go in the ankle and the calf, it's like squeezing a tube of toothpaste from the middle. So all the fluid goes up and goes down, but what you need, the reason why the compression through the foot is important is because you're squeezing the tube of toothpaste from the bottom. You have to get all that fluid out from the bottom up to the top so you can reduce the inflammation and the swelling. And it's super, super important to find compression in the foot. It's also very hard to find compression in the foot. So there are very few socks. I've seen thousands, literally 20,000 socks. And very, very few of the compression socks that I've seen actually have compression in the foot. So make sure when you're looking for them, you look for compression in the foot, or you come to Alleviate. Come to the McGowan's, Dr. McGowan, Dr. Henne's office.
So this is basically we cast for custom orthotics with using a scanner technology. So this is what it's a little handheld facial scanner, but it captures the whole foot. So once we have your foot like that, we're able to upload it into the actual software. So it can tell us where we need to adjust the orthotic. We can make little modifications on it. We have patients who come in and they have like big old callus right here. We can take all the pressure off of it and just goes away, which is kind of cool. But then what we do, and I have one printing, so you guys, if you want to look and see how the 3D printer works.
Security check.
But we actually print them off, and we can make these accommodations for each person's like foot and ankle problem. It's pretty cool. It's newer technology, and so far, like since we've been doing them ourselves, patients have been a lot happier than when we send them out. which has been really kind of nice.
More importantly, when they're not happy, so when they don't like it, we can fix it. But
Yeah.
back in the day, you couldn't really change anything or do anything. You just had, here's your prescription, deal with what you're getting. Nowadays, we can kind of tweak it and do what we need to do.
The other thing we do have, which we don't do, I never really push this for patients, but we do have, because not everybody loves Birkenstocks, and it's the only type of sandal we can actually print off as a Birkenstock. So we've had some success with our patients who only wear sandals, but not everybody wants a sandal that looks like a Birkenstock. So it's really neat, but it's something that insurance doesn't cover. So I don't, if somebody comes in asking for it, I'll do it. But otherwise, what's that? Did you say something? No. But it's nice for somebody who needs the support. We're playing around right now with the biofoam boxes, so we're actually able to mail that to people that are
People
far
go, I
away.
really love your orthotics, but my dad's in Texas. What do I do? Well, we got a backup plan for you.
Yeah, but this is not my favorite because we have to leave it up to the patient to cast themselves. And then what happens is then we have the impression of the foot, we scan it, and then we can make the orthotic from that. But it's better to be in the office,
Totally.
I think, to get scanned. And then that's our family, and that's really the end. We're definitely around for any questions. If you guys want to take a peek at how the printer works, we have that up and running in the back. Just don't look in our office; it's messy. But yeah, that's it. We're here in our Claremont office every day of the week, and then Leesburg. We have an office we bought in Leesburg. We're there 2 half days a week. But and we do this in both offices. We do everything. Any questions?
What is your office in Leesburg?
Our office in Leesburg is right next to the Leesburg Hospital. We're South Child Street, and then there's Old Dixie Highway. So before you get to the hospital on the left.
The orthotics that I purchased from you,
Yeah.
they can be readjusted or?
Hmm?
No, you did over the counters. Yeah, not over the counter.
Oh, okay.
Over the counter, because your foot. So talk a little bit about posterior tibial tendonitis. So
Say that slower.
So posterior tibial tendonitis, it's almost like can go hand in hand with plantar fasciitis. Those are two things that really, I think, help hold the arch up is your plantar fascia, which supports all the meat and potatoes that are between it before your bones. And then the posterior tibial tendon that comes around the inside of the ankle and attaches to the medial bones there on the foot. And it's supposed to help it. But for women, it's very common it's the most common age group to get posterior tibial tendonitis is over 40. I think it's because we work harder than men. So we're always doing stuff, right?
Yes.
And so, no, I'm just kidding. But
I agree.
but the deal is with that posterior tibial tendonitis, over time, it kind of just starts to wear a little bit more. That tendon's getting weaker. That overpronation keeps happening. So as you're going from heel straight to toe off, your foot keeps pancaking out and flattening out. Well, we tried the over-the-counter first, but the over-the-counter, because it's not custom for your foot, we just have we have like every other brand. It's a very standard what will help most of the people, but if it's not helping you, the next step is to go for every nook and cranny of the foot, do the scan, because that I can play with forever. And I will tell you, I have patients who've had flat feet that we've scanned for orthotics, and those challenging. And like I said, I think I've had 4 people that I've had to maybe redo their orthotics like 4 times before I got it perfect on a flat foot. Like we're getting a little bit more part of that medial midfoot delled out, so it's a little bit more comfortable. It's still giving you support, so their foot's not pancaking out. But yeah, the over-the-counters, they're great for plantar fasciitis. They're great for new posterior tibial tendonitis. But if it's not working, it means you need something higher.
How do
Okay.
you know if it's adjusted correctly? Is it like subjective or?
So that's a great question. I think orthotics have always been, since the beginning of the time, a little bit of an art with the science backed. But the science we have now is so much better than we used to use the plaster cast. So for example, what I do is I work with, I'll go back, I'll look at the scan. So I have this thing called an STL file. So it's the actual foot. And I can actually say, you know what? I can see, and it's definitely a little subjective. It says, maybe I need to move the arch a little bit because I can see it'll hug up there. And I can actually do that on the computer software instead of look at it and be like, I don't know, I'll just scrape right here. I don't do that. I'll just reproduce a whole new orthotic.
And then what you tell us, we come in, what? I feel like it needs a little more here. It leaves it really kind of bothers me here. And
Yeah.
no problem. You adjust. It's easy.
No, especially somebody who's had a flat foot and has been pronating for so long in their whole lifetime. Sometimes what the science tells us is not what their body's saying feels quite right. So it is a little subjective, I think, in
And
that
people come with real
sense.
bad flat feet and say, I tried all these orthotics and they're jamming up their head. Well, yeah, because it's not going to fix it. The only way you're going to undo that is to operate, move it. The goal isn't to fix it. The goal is to protect it. Okay, it's 80% science and a 20% feedback art.
And as far as indications for doing this, is it more cavus versus planus, or like what's the foot look like generally? Or
They're more planus. They're more flat. So caves and planus are kind of like foot types. Pronation, supination, that kind of like terminology. It's just one's a flatter foot, one's a more high arch foot. And so I have seen some people who've had terrible plantar fasciitis with a cavus foot, and they do really well with a custom orthotic.
Correct.
And I've seen people who have a very flat foot, but plantar fasciitis, and they do good with an over the counter. But then when you get into the nuances of, is it posterior tibial tendonitis? Do they have midfoot arthritis? So we need more contact. We need something more custom. But the custom, I think, it really
depends on the patient's problem, in all honesty.
It's really not the foot type. It's more like, and what have they done before? Have they done all of the conservative things? Have they tried an over the counter? And a lot of times, whether the foot's cavus or it's planus, so whether there's high arch or low arch, if they've tried an over the counter and they've done well, but they're not at least 70%, then going into something custom, I think, can be a winner.
Typically treat people for a while, and if they're not making progress with anything I can do, then I'll send them to you guys.
Yeah, perfect.
So, custom orthotics aren't for everyone, but then there's a lot of people can benefit from it. And we don't, it's not like we're doing thousands of them. We just do them for people that need them.
A lot of times my patients will ask how insurance works with it. So what do you typically see?
Oh, yeah. So if you're Medicare, insurance doesn't cover it at all. The only thing Medicare covers is diabetic, and it's accommodative inserts, so the ones that kind of break down over time. That material is a failure point. Most insurances, so what we've learned over the last 2 years is most insurances don't cover it, but a lot of insurances will tell us they cover it. So then we'll go through the whole process. We've started giving patients prescriptions. If they want to have it done somewhere else, we give a patient a prescription. And we send them to either Saunders or Henne, and we say, hey, listen, when you go, make sure you explain to them that you want to know exactly how much it's going to be before you pay for this. So we don't pressure patients into like necessarily getting ours if their insurance will cover it. But we don't deal with the insurance at all anymore. So I'll say, hey, go to Saunders. If they say it's covered and they can give you that guarantee, then get it there. Definitely get it there. But if they tell you it's going to be $1,000, come back to us because we charge $550 for the custom orthotics. So we're like a lot cheaper than going to one of those bigger places that are orthotists.
Yeah, the biggest issue I've personally had with insurance is, for instance, like Blue Cross Blue Shield. So if Blue Cross Blue Shield will call, we'll have everybody call, we'll have everything in writing.
We have somebody that verifies insurance.
But I think the patient do it too, because that way the patient gets mad at their insurance. Yeah. We used to bill it and it'd say, yeah, it's approved $900. Like, yes, we're getting more than we normally charge. But then they have deductibles. So now the patient is paying me twice as much as they would have won if they paid for themselves, and so they get all mad at us. Or you'll bill it and they'll say everything's there, and the patient's insurance say, well, it's really not covered, and you're kind of in it. So I don't do it. I say, people, if you want to use your insurance, here's a prescription. Make sure you know exactly what it is before you run any credit card, and we're $550. We can probably beat it. And half the time they come back 6 months later because, they want all our notes. We'll send our notes and their insurance company will say, well, it doesn't say this. Well, yeah, that's not
because they didn't have it. That's not their problem. We can't change their medical record.
I can't lie for you to get it covered for this guy.
Yeah.
And just, if we do lie, you're going to probably get burned anyway. It happens all the time. So I don't do that stuff at all. I say, here's a prescription. If you like it, perfect. You never need to come back for another prescription. Give me a call. I'll fax it there every year you want a new one. But 9 times out of 10, they come back angry about something. Either it wasn't paid for, they don't like the thing. It took 6 months to get it. I'm like, perfect. I can have one ready for you. Like if I do one on Friday, it's ready Monday. Within 2-3 days, we can have it done.
Yeah.
If you don't like it, I'll fix it.
Yeah. And then we have the patients that go to the good feed store They spend like $1,200
Oh,
on
they
a
get so bad.
non-custom orthotic and all this other stuff.
They
Or
come
our
in and spend
patients that go-
$1,200 on this. It's $12 on Amazon. You go right to Amazon,
Yeah,
you
you
can
go
buy
on
the
Amazon,
exact
find the
same
same
one
things with
for
fees, right.
$12.
The other thing that like we see a lot too, patients will go on a cruise, and I don't know if they got the drink package or something because they come back, they spent $800 on something that they took an ink impression of their foot and then gave them an over-the-counter insert.
And it's usually the same one as the good feeling. It's got the multiple, you can switch the thing out. I'm like, yeah, you can buy the same one for $18 on Amazon.
Yeah.
Like, why did I spend that? I'm like, because you were having too many margaritas.
I went there, it was like $1,000 for three orthotics.
Yeah,
Yeah,
they're
it's
all-
one orthotic with this. And everyone's like, it's custom. It's not custom. It's customizable. They want you to kind of mess around.
You have to
with it.
decide which one feels better. So
Yeah.
they give you
But-
3 things.
But either way, you could have bought it on
Yeah.
Amazon for $18.
Yeah.
I go to Amazon. There it is. Like, oh man, I'm like, I know.
Yeah. But yeah, we went on a cruise once and bought the drink package. And then Tim's like, we have to have 19 drinks a day. I'm like, I can have 19 drinks a day. That's not even, that's not
The
possible.
smoothies counts. Our kids
Yeah.
are getting
Our
smoothies
kids are
every
getting
5
smoothies,
hours.
but anyway, any other questions? No?